Hello, my name is Valerie Harrison. Today is Saturday, December 28th, 2019, and this is my video presentation for Case Connection 4. I first chose to discuss Case 1, in which a newborn girl appears normal at birth, but within 24 hours she develops lethargy, hypothermia, and apnea. The best diagnostic test to distinguish between a urea cycle disorder and a beta oxidation disorder would be choice D, plasma glutamine. The urea cycle exists for the removal of excess nitrogen from the body, and there are 6 separate enzymes that compromise the urea cycle. A deficiency in any one of these enzymes would cause a urea cycle disorder, and this is usually present within the first few days to months of life. Most urea cycle disorders are distinguished by a characteristic profile of plasma amino acid alterations, which can be utilized for diagnosis. In the case of blood glucose levels, this is actually used to determine the amount of glucose that's in a patient's blood. This is commonly used to diagnose patients with hyperglycemia in the case of diabetes. Urinary acid levels would also not be the best choice for this patient. That is due to this test being used for compounds found in the urine that are produced during daily metabolism. It assesses profiles that are in major metabolic areas that can be compromised by major lifestyle and dietary factors such as nutrition deficiencies. And in this case, this patient's a newborn, so she doesn't really fall into the age range for this type of diagnostic test to be used. Testing a patient's level for serum fatty acids is also a common test that's used to determine the amount of fats in a patient's blood. It's commonly used in patients who have inflammatory disorders, cardiovascular issues, hormonal disorders, and others. For this patient, this would also not be the right test to determine whether her disorder is urea cycle or beta oxidation disorder. The only test here that really helps to determine that would be plasma glutamine, since this is a primary diagnostic test or finding that's associated with all urea cycle disorders, and it actually presents as neonates, such as in this patient's case as a newborn. Also, in the case of beta oxidation disorders, glutamine levels are usually normal, which helps us determine that this is a urea cycle disorder and not a beta oxidation disorder. Based on the patient's full blood workup data, she has very high levels of orotic acid, which helps us to determine that the enzyme that's most likely deficient is ornithine transcarbamylase. This enzyme is one of the 6 enzymes that play a role in the breakdown and removal of nitrogen in the body, so in the urea cycle. The lack of the OTC enzyme will result in excessive accumulation of nitrogen in the form of ammonia in the blood. And excess ammonia is neurotoxin, which means that it will travel to the central nervous system through the blood and cause symptoms such as vomiting, lethargy, and can even cause coma. The onset of this deficiency can actually occur within 24 hours after birth, such as in the case of this patient, and it can progress into symptoms such as seizures, hypotonia, and hepatomegaly. A mutation in the OTC gene is what causes the deficiency due to the gene providing instructions for making the OTC enzyme. Due to this deficiency, carbamyl phosphate accumulates in the mitochondria, and it then leaks into the cytoplasm, where it is then redirected into pyrimidine synthesis, resulting in raised levels of orotic acid in the urine. So this would make the enzyme least likely to be impaired, for this case, carbamyl phosphate synthetase 1. My second case I decided to discuss. I commonly see myself every day at work since I do work with podiatric surgeons. So I chose case 3, which is in the case of the patient with gout. Due to this patient's switch from diet soda to regular soda, it can be a route to why the gout has presented itself because of the high amounts of fructose that this patient is taking in one day. Gout is due to a presentation of uric acid disturbance, which is also known as hyperuricemia. It's a systematic disease that results from the deposition of monosodium urate crystals in tissues. Increased serum uric acid above a specific threshold is a requirement for the formation of the uric acid crystals, and gout is mainly diagnosed by identification of the pathogenomic MSU crystals by joint fluid aspiration or in TOFI aspirate. Patients with gout have an overproduction of purine nucleotides de novo. This is the cause of hyperuricemia in a substantial portion of patients with gout. Specific enzyme deficiencies of hypoxanthine guanine phosphoribosyltransferase transferase, which is an enzyme of the purine salvage pathway, and overactivity of 5-phosphoribosyl 1-pyrophosphate synthetase can also result in hyperuricemia. These are all associated with the increased de novo purine synthesis, as well as increased intracellular concentrations of PP ribose P. The latter is a common substrate for the first enzyme of the de novo pathway, phosphoribosyl aminotransferase, and the purine-based salvage enzymes. It has been shown that elevated intracellular PP ribose P concentrations may increase the rate of de novo purine biosynthesis. The exogenous purines exert a feedback effect, not only on the first step of the de novo pathways, but also at the distal branch point in the pathway. When it comes to decreased urinary excretion of uric acid, this is the end product of an exogenous pool of purines and endogenous purine metabolism, which varies significantly with diet. Hyperuricemia can result from the increased generation of the uric acid, and this can be due to diets that are heavy in purine or in fructose, which can contribute to high uric acid levels. This patient's switch to soda, which is very high in fructose, could be a major reason as to why he has developed gout. Fructose is a unique sugar molecule in that it actually rapidly depletes ATP and increases the amount of uric acid in a patient. High levels of blood uric acid is also associated with gout, and the balance of uric acid formation and excretion is driven by several enzymatic pathways which occur via different genetically defined isoforms. Xanthine oxidase is the rate-limiting enzyme in purine catabolism, and it is the most relevant pathway that's involved in uric acid overproduction. Uric acid is actually the final breakdown product of purine metabolism, and that is what we excrete in the urine. So when there is an overproduction of the uric acid, it will cause an inhibition in part of the pathway, which will ultimately lead to a decrease of the uric acid excretion and cause that uric acid to build up within the joints, such as in the case of this patient consuming high fructose levels, and would cause this patient to suffer from hyperuricemia, or most commonly known as gout.